If the trial is successful and the patient enjoys the relief that they got from that electric impulse, then we can come back and implant this basic dollar-sized coin type machine that is connected to the wires and is put under the skin.
I'm very tempted to ask, if the Neuralink that we keep hearing about works on a similar principle. But again,
I don't know
yeah,
about Neuralink.
yeah,
I do probably think it is electrical impulse,
yeah.
initiated,
Mm-hmm.
but it's in the brain. But it is the same concept, which is,
Yeah.
the combination of man and device.
Welcome to a brand new episode of On the Stand with Ashish Arun. Today, we're going to look at the intersection of pain management and the legal field. Our guest today is Dr. Simon Dardashti, a distinguished pain management and anesthesiology physician with over a decade of active medical practice. Dr. Dardashti is double board certified in anesthesiology and pain medicine, bringing extensive expertise in risk management, case review, depositions, and he's also working on a trial. He used to be a clinical professor at UCLA, and as an expert witness, he has contributed his insights to both plaintiff and defense cases with a balanced approach to medical malpractice, personal injury, and complex pain syndromes. His hands-on knowledge of advanced treatments like spinal cord stimulation and radiofrequency ablation, combined with his ability to clarify complex medical concepts, sets him apart in the field. Dr. Dardashti, thank you for joining us today.
Thank you for having me.
So let's begin and ask you about your background as a doctor and how you got into the world of expert witnessing.
I have been practicing out since 2014.
Mm-hmm.
And over the course of a decade of being a pain management doctor, treating neck pain, back pain, all sorts of different types of pain, I, as a treating physician, would oftentimes get deposed as a non-expert. And when they would review my records and when they deposed me, a lot of the lawyers would give me feedback saying that I was able to explain difficult medical concepts very clearly. And I kept on getting that feedback over the years. And it was a point where one specific lawyer said, "Hey, you should consider going into the legal field. We could really kind of use somebody who can explain these type of concepts to us like you do." And so I've slowly over several years kind of got into it more and more.
So pain is a very difficult concept to explain because, again, like based on my limited understanding, and please correct me if I'm wrong, but pain can be very subjective. Like my pain can be very different from yours. I can be more sensitive towards pain. And so it can be very difficult as a concept to understand for the judge and the jury. So how do you go about looking at pain that a person is suffering and experiencing, and then explaining that to the attorney and then later to the fact finder?
It's a good question. It's a common question I also grapple with just in my own clinic, not just in the
Mm-hmm.
legal world,
Yeah.
because of exactly what you said, that pain is a subjective experience, meaning that two people could experience the same injury, but have different perceptions of the intensity of the pain. Sometimes the kids would be taught, hey, just rub it off if they fell down and scraped their knee. And other parents might tend to every concern of their kids, which kind of goes into concepts of fragility and anti-fragility that you're seeing in child psychology. And that will reshape and remodel how the brain perceives pain. In regards to the question about how do you assess pain? And that is kind of the way in clinic we have several modalities. One is we'll have specific types of standardized pain scores. We'll assess the patient's functionality day to day. Some patients will be in 10 out of 10 pain, but then when you ask them, are you able to function daily? Are you able to drive? Are you able to go to work? And they say, yeah, I'm not limited day to day. So pain and functionality go hand in hand. And we also use x-rays or MRIs, imaging findings that will kind of give us a little bit more insight into whether the location or type of pain the patient is complaining about correlates with the imaging findings or doesn't correlate with the imaging findings.
So that brings me to my next question. So let's say I'm in an accident and I have a broken leg. Now, the imaging can show that the leg's broken. And because it's a recent accident, I'm in acute pain. But I can end up with chronic pain. Now, the imaging will not show that there's pain. That's one. And then there's also this whole stigma around chronic pain. Are you making it up? Is it psychological? Are you really even experiencing this pain? So we know that the pain is subjective. Even the acute pain can be subjective, that you and I, we can experience the same pain differently. But what's your take on the difference between, and this is from a legal perspective, and please feel free to add the medical perspective too, that how the perception changes when it comes to acute pain and when it comes to chronic pain?
So the textbook definition of acute versus chronic is whether the pain that first started lasts for more than 3 months. It's much more intricate than that. There are other issues that you kind of delve into, the type of injury, how long does that type of injury usually last, or how long does it take to heal?
Mhm.
So, in terms of the stigma of chronic pain, unless someone has dealt with it themselves, it's kind of hard to empathize, as well as not just treating pain, it's the anxiety that patients endure that I've been in pain for 2 months now, 3 months now. And usually, whenever I hurt myself, I'm better by now. But now I am at the point where not only am I having pain, but the pain's getting worse. Is this my life, my new life? And
Mhm.
people start to have more frustration, anxiety, stress, and that fear of being in chronic pain for the rest of their life can be very debilitating mentally. And so you have to manage those expectations, discuss the type of pain that the individual is enduring, and a lot of times giving the patient hope that they are going to get better, but they have to do XYZ to improve goes a long way
Mhm.
to kind of reshaping the individual's perception of their own condition and then getting better. And in regards also to the stigma of chronic pain, I did look at the podcast you had with Mr. John Pools, who
Mhm. Yeah.
dealt with mental health and addiction. And part of pain management is opiate management. And the fact that we are currently having an opiate epidemic in America, we always are very wary to kind of make sure that those medications are used responsibly and in accordance with CDC guidelines and government guidelines, the FDA guidelines. So yeah, there is a stigma, and there is a time period which goes from acute to chronic. And when you are treating pain, categorizing the type of pain, categorizing the type of injury, whether it's a whiplash injury from a car accident or whether it was from a medical procedure that didn't go the intended way due to an infection or nerve damage, assessing those individual cases will help kind of the attorneys and the patients get a clarity on what's going on.
Yeah. So let's talk about some of these cases that you review for plaintiffs' attorneys. And I understand that you do quite a bit of pre-litigation work as well, and you also offer your expertise when the case goes to trial. So, how does your role as a pain management expert begin? And when it comes to, let's talk about medical malpractice first. So, what kind of cases do you usually look at? And at what stage do attorneys usually come to you with medical records? And what kind of questions do they ask you to look into?
Yeah, I chose pain management as a field because you have to get a little bit of everyone else's field in the sense that there's bone pain, there's nerve pain, there's muscle pain. So you need
Yeah.
to know a little bit about oncology and cancer. You need to know about sports medicine and orthopedics. You need to know about neurology. And because the pain can present in so many different ways, the type of cases I get both in the clinic and from attorneys is just so wide ranging. With medical malpractice case, like a recent one that I had, the individual got a joint infection. And what ended up happening is that the joint became infected. It was a grandpa of a family who was very dear to the family. The daughters had a very strong connection to the father, and they were very upset that he had an infection. And they felt like they went to a good clinic and a good hospital and everything was done, but they just couldn't figure out what's going on. Why did he have that infection? And so the attorney approached me and said, "This is the situation. Could you please review the medical records?" And we reviewed the case. And in this case, sometimes the doctors might have a breach of care, which means that they behaved or treated the patient in a way that is not the standard of care that another clinician would perform in that same situation. And then sometimes the doctor does actually do appropriate standard of care, but the outcome is still unfavorable. And sometimes infections happen. Sometimes they happen due to lack of septic technique. Sometimes they happen due to maybe a method of doing the procedure that is still antiquated and we know can increase the risk of infection. Or sometimes it's due to the patient's own medical issues. And in this particular case, thankfully, there was no injury that was long lasting, but the family was still upset. And on review of the records, everything thankfully was done properly. And then I expressed that to the attorney who understood um, and also expressed his opinions and kind of saw things when I explained it to them and understood it from a medical perspective. And he had actually asked me to have a meeting with the family to explain to them from a doctor's perspective why things were done right or were not done right, whether this is something that occurs. And some people they think that there are no issues that ever happen in life or in medicine. Some people they just want closure that things were done properly. And once they know that they haven't been wronged, a lot of that psychological impact of injury is so I find both in my clinic and legal practice dealing with patients, or as the attorneys call them, our clients, we still treat them as patients, then it really makes a difference for people.
And do you think that's a rare practice to make the reviewing physician talk to the patients to get them the answers, get them closure, or do you see that happening like more often than not?
I see them happening more often than not. A lot of times the attorneys will kind of ask me, well, yeah, thank you for explaining it. Thank you for clarifying it. How would I phrase it with my client?
Yeah.
And so I'll explain to them how I would phrase it, or they'll have me talk to them. But I do think that managing the individual's understanding of the situation goes a long way.
Mm-hmm.
And we in life underestimate how much we make assumptions. And so when we talk to individuals about a case or about an injury, we just listen to what their concerns are. Then we get a better understanding of where they're coming from. And then we can kind of clarify maybe misunderstandings or assumptions that were partially correct or not correct or full or correct. And kind of once they get a better footing of what the medicine is and how it's done, why it's done, then they start to see things differently.
Mm-hmm. And a lot of times, attorneys, like not all attorneys, but some attorneys can be a little aggressive when you tell them that, okay, there's an unfavorable, like an undesirable outcome, but there was no malpractice. And these two things are different. And they would try to pressurize the expert or go at the expert from different angles, trying to figure out, okay, is there a case that I can take to court? So, have you had that experience with any of the attorneys who sent you records to review? And how do you deal with that?
Thankfully, I haven't had that many issues. The majority of the attorneys that I've dealt with have been very professional. I have heard those stories. I think because I'm very clear, justify my position, it's harder for an individual to kind of maybe not see things the same. If you make your opinion about the facts and you point to different areas of the records, then the record speaks for itself.
Mhm.
And one thing I've learned about being a pain management doctor and having to deal with different individuals is to be very, and once the other individual, whether it's a patient or attorney, knows what to expect of you, then they have a better footing about
Mhm.
the situation long term.
So, can you talk a little about the role of imaging studies in your evaluations? Especially comparing pre-injury and post-injury imaging, and how important of a role does that play in your evaluation? And do you have any, like tips you'd like to share, or any like specific comments you'd like to make on?
I find pre and post injury imaging to be very, very helpful,
Mm-hmm.
both from just a clinical perspective, but also from a legal perspective, because there's something that you can objectively discuss and point to. Major part is I'm always trying to request from my attorneys more records. And it's not always easy for the attorney, but it ends up being worthwhile because if you can get more of the background, you have a better story and you have a better understanding of the situation. I find that having like a baseline x-ray or MRI before and then assessing for the type of injury and location of the injury to the human body and then correlating that with the imaging goes a long way. And for that reason, even in my own clinical practice, if someone is in chronic pain, we tend to get a repeat MRI after a year or two to assess what has changed, why they're in more pain, or if there are no changes on the MRI, a lot of times the MRI will show arthritis or nerve issues. But
Mm-hmm.
often, when I explain to patients, well, the MRI doesn't show necessarily muscle strains as much. It shows to some degree, but it might not show the change as well as other things. Then we would be focusing more on the muscle aspect and tendon issues that might be chronic or acute.
Mm-hmm. So, Dr. Dardashti, I'm sure, like the rest of medicine, even pain management has evolved significantly over the past few years. And while preparing for the podcast, I was reading about some of them, and I came across terms like spinal cord stimulators and radio frequency ablation. So, correct me if I'm wrong. What are the new technologies that you are seeing in pain management being used or you are using yourself? And how do they compare to the more conservative approaches of physical therapy and medication management?
We always start off with physical therapy, exercise, changing your diet from an pro-inflammatory to a non-inflammatory diet, more vegetable-based, goes a long way in terms of treating inflammatory processes and muscle strains. And then with time, if you give it a little bit, several weeks or a month or two, you try to assess, is the patient still in pain? And
Mhm,
after that, why are they still in pain? And did the imaging correspond with that level of pain or the initial injury that occurred? And if the patient doesn't respond to physical therapy or medication, such as muscle relaxants, anti-inflammatories, there's nerve medications that are very common, then you say, hey, this patient isn't responding to the initial treatment. That's when you start to figure out, do we need to do a procedure and what type of procedure and why? And as we categorize the pains, whether it's nerve pain, which you might consider doing an epidural for if your patient's having sciatica, or if
mhm,
the patient has already had epidurals and has already had spine surgery, and then might be a candidate for, as you mentioned, the word spinal cord stimulator, which is a newer technology
mhm,
that is becoming increasingly used. It is initially a true trial leads that are basically the size of a spaghetti strand that
mhm,
you put in the epidural space. We take you to the procedure room, we disinfect the back, we lay the patient on the back, and we use a fluoroscopy x-ray machine to pinpoint the epidural space. And then we take the two wires and we insert them in the epidural space right outside the spinal cord. What do these wires do? They're connected to a little machine that sends an electric impulse.
mhm,
And because all our nerves and all our nerve pain is electrical from our fingertips and toes to our spine and to our brain, we can actually send different frequencies using these two wires against the pain signal that the patient is suffering through.
mhm.
And you put those two wires in, they wear them for several days, and it's actually nice. You just end up removing the trial leads. And then you just put a band-aid on the back, and then the patient thinks about whether they got relief, were they more functional, were they able to bend or walk easier.
So, Dr. Dadashti, I can see you have a model as well. So, can you help our listeners and attorneys understand this better by using the model and explaining the concept to them?
Absolutely. So here we have a spine model, and here we have the two spaghetti wires. And you see they're fairly small, and we just thread these two wires into the epidural space. And these wires end up sending the electrical impulse. Fairly small, and the trial is only several days. And that will a lot of times help individuals who have nerve pain despite treatments such as injection, surgery, or medication.
Mhm.
If the trial is successful and the patient enjoys the relief that they got from that electric impulse, then we can come back and implant this basic dollar-sized coin type machine that is connected to the wires and is put under the skin. This machine, even though it's small, can connect to Wi-Fi, can be reprogrammed to multiple different settings, different
Mhm.
locations, different intensities. There's representatives from the device company that help facilitate that. And the advances in spinal cord stimulator devices since I came out of training, even just 5 years ago, let alone 10 years ago, has made leaps and bounds.
I'm very tempted to ask if the Neuralink that we keep hearing about works on a similar principle. But I mean,
I don't know
yeah.
about Neuralink.
Yeah.
I do probably think it is electrical impulse initiated,
Mm-hmm.
but it's in the brain. But it is
Uh,
the same concept, which is the combination of man and
mm-hmm.
device with like knee replacements, hip replacements. Now we actually have devices that you can program that's inside the human.
Mm-hmm. So, talking about Neuralink, what other uses of AI, if any, like this is a big pivot from what we have been talking about till now. Are you seeing uses of artificial intelligence in the line of work that you do on the medical side, one, and on the medical legal side as well?
This is a hot issue, and in clinic, vast majority of doctors now are using AI with the
Yep.
patient's permission
Mm-hmm.
to record the conversation. And so you have more face-to-face time with the individual as opposed to just being on the computer, which is frustrating for both the doctor and the patient. We enjoy seeing the patients and connecting with them. So now we have AI devices that record the history and also physical exam as you kind of announce it to the AI recorder. By the time you leave your clinic and get to your office computer, everything that was discussed is organized in a cohesive paragraph and bullet point format. And it's a
Mm-hmm.
big time saver,
Yeah.
and it just helps patients get more out of their experience.
No, yeah,
And that's on
yeah,
the clinic side, yeah.
yeah, no, that's really useful. In fact, I have a professional friend called Dr. Chris Brigham, and he's in fact working on something similar, where he's using AI to help doctors with medical history taking, where the
Right,
AI
right.
is helping up with questions to ask. So, and I've seen a demo; it's pretty nifty. So I can imagine like you're using something like that on those lines, and I can see how it must be saving a lot of time. And yeah, as a
Yeah,
doctor, your focus is now not on like taking notes or summarizing while you're with the patient, so that you can completely focus on the patient and give them your full attention. So that's really
right.
useful. Let's talk about the medical legal side. Have you seen any interesting uses of AI there?
Um, I so far on the legal side, I haven't had that same success just because having to go through the medical records, having to tease out those specific points, it's really a detail-oriented profession.
Mm-hmm.
And I personally used it a couple times, and I did not feel the quality of
Yeah,
analysis was to the standard that I personally would like.
yeah.
And having corresponded with attorneys, being on certain attorney group memberships that deal with medical and legal, there's calls involved because you cannot let the AI think for you. And so when I presented at a recent MCLE continuing legal education course for attorneys, it was one of
Mm-hmm.
the points that I made that using AI in and of itself without double checking the work.
Oh yeah, recently, like talking about AI getting people in trouble, you'd be surprised. The founder of the Stanford University's social AI tech cell, he was testifying and consulting as an expert witness on AI in a case involving deep fakes and the dangers of using deep fakes. And he ended up using ChatGPT to write his report. And the report was fine. There were no issues with the report, but ChatGPT gave him two hallucinated citations to papers that did not exist. And he usually used a AI citation checker for his academic use to make sure that the output has no hallucinations. But for the expert report, he failed to use that, and he did not check the report properly, and the court excluded the whole report because of that. So, I mean, the irony was not lost on the judge. Like in an AI related case about the dangers of AI, the expert
Right.
witness has used AI and failed to double check. So, this was in the news everywhere. And last week, the order to exclude the expert came out. So that risk is always there. In fact, we use AI a lot in preparing for the podcast or doing our social media posts or writing content for our website. But everything we do will double check, edit it out, make it look like, and make sure that when it's going out, I'm okay with taking responsibility for every word that whatever piece of content we are putting out. And for experts, the bar is just way, way higher. So that's sensible. So when you started, you told me that you were being called to testify and explain these concepts as a treating physician. And then attorneys told you that, okay, you are really good at explaining things. And that's, all the attorneys we've talked about, they've all said that I don't care about the credentials as much as I care about the ability to explain concepts. Because at the end of the day, you are a teacher to the jury. And if the jury can understand, can relate to you, that is the biggest quality in an expert that they look for. So when you got that feedback and you decided that, okay, I should probably look into doing more expert witness work, what were some of the first few things that you did to try and get your name out? Like you told me you did an MCLE recently. That's a great way of connecting with attorneys. You also told me that you are on a couple of attorney expert groups that do medical legal work. So other than that, are there any other things that you have done recently so that new experts who are trying to get into this field can benefit from those pointers?
You make several good points. One is that one of the meanings of the word doctor is teacher. And the same way in clinic, I have to explain these concepts to patients so that they understand what's going on with their body. Explain it to any individual. Um, Having spoken to the attorneys, one thing I realized is at the end of the day, it has to be clearly understandable to a jury, which is a layperson. And so that's why I get the sense that you do, which is having an individual who can explain things simply and
Yeah.
clearly makes a big difference.
Mhm.
And in regards to just reaching out to different attorneys, I do feel that reaching out directly to firms that specialize in your field is very helpful. I enjoy the MCLEs because I learn a lot from the attorneys.
Mhm.
I never want to make assumptions about what they think is important. From a doctor's perspective, we might think that this MRI or this diagnosis is important, but from the attorney's perspective, there's a lot of other things going on in the case that you as an expert are probably not aware of or might be a big issue. So kind of understanding their side, understanding what their priorities are through the MCLE or just networking with them individually goes a long way. I also find that finding different legal groups, given the fact that we have the internet, now we have AI, podcasts are becoming more niche, and so are any type of interest in life. When you go on YouTube, every single nook and cranny or interest, the most esoteric, unique issues are now getting, 50,000, 100,000 followers. And I see it now with my kids too, who love YouTube. They
Mhm.
find these unique ideas, and then there's somebody who creates a whole podcast series about it.
Yeah.
Good. So, one thing I encourage the listener who wants to reach out to the attorneys, like you are as a medical expert or any type of expert, there is an attorney and they're very bright. The attorneys know a lot of medicine. That's why I enjoy the MCLEs. They understand the diagnostic criteria. There is a specialist on the other side in the legal, and finding those specialists, it might take a little bit of time, but it can be done, and it helps the attorney. It helps you. It helps the client. It helps the judicial system who needs clarity on concepts that we as individuals take for granted because we deal with it day in and day out.
No, it definitely does. I really think doctors play a big role in, like maintaining the sanity of the judicial system, especially in med mal and PI cases, because more so in medmal, because you can't even file a case unless and until you have a certificate of merit from a doctor. Unless obviously the malpractice is so obvious that you don't need one. But yeah, I mean, without doctors, so many of these people who get injured, get harmed, they would not see their day in court. So really, like, thank you for everything that you do. If people want to reach out to you, what's the best way to get in touch with you?
The best way to reach out to me is just to email me directly at
Mm-hmm.
expertmedicalservices26@gmail.com. And my website is painmanagementmedicalexpert.com.
So we'll put both these things in the show notes so that people can easily reach out to you. Any last comments you'd like to make about being an expert, promoting yourself as an expert that can help our listeners?
Just know that um, each case is unto itself, each injury is unto itself. And so, one of the nice things about the legal field is that individuals have a voice.
Mm-hmm.
And so, I think that makes that field special.
Great. So thank you so much for your time, Dr.
Thank you
Dardashti.
for
It was an
having me.
absolute pleasure talking to you. And I think that, like you brought out that model for our viewers and listeners. Like a lot of people watch the podcast on YouTube and on Spotify videos. So that'll be really useful for them as well. So thank you so much. It was a pleasure talking to you. And I really hope to talk to you soon again.
Thank you very much. Wishing you continued success with Xlitum. And thank you for having me on the podcast.
Thank you. If you found this podcast useful, remember to subscribe and give us a review on Spotify, Apple Podcast, YouTube, or wherever you listen to podcasts. This will help other users find this podcast and benefit from the insights shared by our guests. If you'd like to be featured as a guest on this show, please write to media@xlitum.com. See you in the next episode.